Assalamualaikum. My name is Kamal. First of all, I welcome all of you. Today, I am moderating this webinar, and our topic is fertility and PCOS the way forward. Firstly, I would like to share the brief overview of this program. We will start with the recitation of Holy Quran, and I will share the brief summary of and then there will be the presentation of subfertility and PCOS by Professor Dr. Fareesa Waqar, and at last there will be question answer session. So moving towards the program, in the name of Allah, we will start with the recitation of Holy Quran. Now we are moving towards the brief history of Australian concept. I would like to share. First of all, I would like to introduce about our director, Syed Sajjad Khan. He is the owner of Australian concept. And Australian concept has successfully completed 22 years of service in the field of IVF, and it's Pakistan's largest IVF branch network. It is responsible for first FET baby of Pakistan. ACIMC is delivering world-class IVF lab services with consistently high success rates. Independently, the quality is assured by Australian scientists on a regular basis, and it's playing its active role in supporting non-affording patients through Angel Trust. We have also trained highest number of gynecologists in IVF techniques and technologies in Pakistan. So without wasting your time, I would like to introduce our Professor Dr. Fareesa Waqar, who is doing this webinar session today. She is MBBS, MCPS, FCPS and HPE. She is Head of Department of Obstetric and Gynecology. She is Medical Educationist and Vice President SOGP. She is a Chairperson Curriculum Committee and Chairperson Morbidity Mortality Committees. She is the member Infection Control Committees, as well as she is Supervisor and Examiner MBBS, MS, MCPS and FCPS. And she has also done more than 60 national and international research publications. She has organized and attended many national and international conferences, and she is playing key role in organizing all ICMEs held by RIFA University, and she is the head of department at IIMC RIFA International University, Rawalpindi. Now I would like to invite Professor Dr. Fareesa Waqar, so please welcome her for her presentation on subfertility and PCOS, the way forward.
Assalamu alaikum, Bismillahirrahmanirrahim. I'm going to start my webinar today, and the topic for today is subfertility and PCOS, the way forward. Since polycystic ovaries, there's a volcanic eruption of polycystic ovaries, and this is a common problem which we are facing these days. And patients who have subfertility, they often complain that they are not conceiving, and we do their investigations. We found that they have polycystic ovarian syndrome. So today, this is just a brief to treat these patients. Polycystic ovarian syndrome is a complex condition that presents with ovarian dysfunction and endocrine problems, and is also associated with hyperinsulinemia and metabolic disease. The prevalence ranges from 5% to 13% in women of reproductive age, and I think in Pakistan the prevalence would be even higher. What is the diagnostic criteria? We all know about the Rotterdam criteria. It is a heterogeneous condition which is defined by the presence of two of the following three criteria: oligoovulation and/or anovulation, hyperandrogenism, which may be clinical or biochemical, and polycystic ovaries are seen by pelvic ultrasound. This is a picture of polycystic ovaries. If you see that this is a typical pearl necklace appearance of the follicles which are surrounding the periphery of the ovary, And the center of the ovary is, instead of follicles, they are stroma over there. And this is very resistant. This condition is very resistant to treatment for and causes anovulation. Most common cause of anovulatory subfertility is polycystic ovaries. PCOS is the primary cause of hyperandrogenism and oligoanovulation at the reproductive age and is often associated with subfertility, clinical and metabolic disorders. The prevalence of subfertility in women with polycystic ovaries varies between 70 and 80%. The causes of female fertility have been given here, and as you can see that majority of the cases are due to ovulatory disorders, and out of ovulatory disorders, 70 to 80% are caused by anovulation. The investigations for polycystic ovaries include laboratory tests such as when we are trying to treat patients who have subfertility with polycystic ovaries, then the tests which must be performed include thyroid stimulating hormone, prolactin, total and free testosterone, DHEAS. Then we must do 17-hydroxyprogesterone. And to differentiate between other conditions such as congenital adrenal hyperplasia, Cushing's syndrome, insulin resistance, and glucose intolerance, we must do 17-hydroxyprogesterone. Evening salivary cortisol, 24 hours urinary cortisol, and HbA1c. We must do all these tests. And other than that, we should do FSH, LH, AMH, and E2 test. But then evaluation of subfertility in polycystic ovaries. According to the American Society for Reproductive Medicine, the evaluation of subfertility in women with polycystic ovaries or other causes of subfertility should start after 6 months of attempting pregnancy. We should not wait for a year. And if you know that the patient is suffering from polycystic ovaries, her treatment should be started within 6 months. Without success, if couple have regular intercourse 2 to 3 times a week and without using contraceptive, even then if they are unable to conceive, then we should start their treatment if the female is suffering from polycystic ovaries just after 6 months. Evaluation of subfertility in PCOS. To optimize the efficacy of the treatment of infertile women with PCOS, evaluation of tubal patency, hysterosalpingography or laparoscopy, and semen analysis are mandatory before deciding on treatment. Tubal patency evaluation may not be necessary if we are only given clomiphene citrate. Management of subfertility with polycystic ovaries. The mainstay of treatment is lifestyle modification. And we all tend to ignore it. Patients who come to you, if you tell them about lifestyle modification, they'll just tell you, give us the treatment. They want a medical treatment, but lifestyle modification is very important in polycystic ovaries. The pharmacological treatment, the first line treatment is ovulation induction with clomiphene citrate and similar medications. Second line treatment is exogenous gonadotropins, IUI or laparoscopic ovarian drilling. And the third line treatment is in vitro fertilization. Pain and lifestyle and counseling of pregnancy complications in women with PCOS. Preconception counseling administering folic acid to reduce the risk of neural tube defect. Physical activity should be encouraged. They should stop using tobacco and alcohol. They should try to reduce their obesity. 5 to 10% loss in body weight over a period of 6 months, regardless of body mass index, may be associated with improvement in central obesity, hyperandrogenism, and ovulation rate. Patients come to you and they tell you that they've been trying to reduce weight and the weight is not coming down, but you should encourage them for weight reduction, because just a little bit of weight reduction can give positive results in terms of pregnancy. Well, these women with PCOS may have an increased risk of congenital anomalies, gestational diabetes mellitus, hypertensive disorders during pregnancy, preeclampsia, miscarriages, preterm births, the need for intensive care, increased perinatal mortality, and cesarean delivery. The risk for preterm birth and preeclampsia appears to be associated with the maternal hyperandrogenism, which is associated with polycystic ovaries. Trained in lifestyle and counseling of pregnancy complications in women, in addition to improving reproductive and metabolic factors. The reduction in body weight may be associated with reduced incidence of complications during pregnancy and the neonatal period. So we must encourage patients to reduce their weight before starting on a pregnancy if they are suffering from polycystic ovaries. In Dewhurst 2018, it is recommended that lifestyle changes, including diet, exercise, and weight loss, are initiated as the first line of treatment for women with PCOS for improvement of long-term outcomes and should precede or accompany pharmacological treatment. Pharmacological measures, the first line treatment is with clomiphene citrate. The principles of fertility treatment initially includes the use of drugs which induce mono or bifollicular ovulation in anovulatory women with PCOS defined according to the Rotterdam Consensus. Clomiphene citrate is the first choice for ovulation induction. The mechanism of action is it acts as an estrogen receptor modulator. In physiological menstrual cycle, low level of estrogen promote negative feedback in the hypothalamus and pituitary gland and inhibit the exogenous secretion of gonadotropin during the early follicular phase. The advantages for clomiphene citrate are it is low cost, oral administration, few side effects. The risk of OHSS with clomiphene, the incidence of ovarian hyperstimulation syndrome, increased capillary permeability with consequent third space fluid sequestration and hemoconcentration associated with the use of CC is low and is approximately 1 to 6%. Then combination of metformin and clomiphene citrate seems to enhance the treatment outcomes, and in patients who have insulin resistance, they must combine metformin with clomiphene citrate. Metformin alone may improve the rate of ovulation, but results of a large randomized controlled trials show that metformin will result in a live birth rate of only 7%. In the same RCT, metformin added to clomiphene confer no additional benefit in terms of live birth rate compared with clomiphene alone. But in other study, this is one randomized controlled trial. In other majority of the randomized controlled trials, they have proven that metformin combined with clomiphene citrate gives is an advantage and causes increased live birth rate. Then pioglitazone versus metformin. Pioglitazone causes an increase in live birth rate as compared to metformin, and it is a better drug as compared to metformin. And aromatase inhibitors. Aromatase inhibitors have been used in women with polycystic ovarian syndrome as an alternative method to avoid the anti-estrogenic effect of clomiphene citrate on the endometrium. The mechanism of action, it reduces the peripheral conversion of androgens to estrogen in ovarian granulosa cells by blocking aromatase. The effectiveness of aromatase inhibitors in polycystic ovaries. A meta-analysis investigated 78 studies on the use of these medications in the subfertility treatment of women with PCOS. 6 studies compared the use of letrozole versus CC, and letrozole also did not actually letrozole has a better outcome in terms of live birth because it does not affect the endometrium and does not thin it out, so implantation is enhanced. The administration of letrozole for 5 to 10 days at a dose of 5 or 7.5 milligrams per day displayed similar clinical pregnancy rates and is of benefit as compared to clomiphene citrate. The second line treatment is gonadotropins. The second line pharmacological treatment of subfertility in ovulatory women with PCOS includes the use of gonadotropins. Gonadotropins include recombinant follicle stimulating hormone, human menopausal gonadotropin for timed intercourse. Prerequisites are due to the higher cost of the therapeutic modality. Before starting FSH and human menopausal gonadotropin, we must do tubal patency because these drugs, their cost is higher. So we must do the tubal patency before we start off with this treatment. and we must do the semen analysis also. The ovarian stimulation begins with low doses of gonadotropins, 37.5 to 75 international units, to achieve monofollicular growth and reduce the risk of complications such as OHSS and multiple pregnancy. Ultrasound monitoring of the follicular growth is mandatory in these cases. Human menopausal gonadotropin and FSH can also be used to induce ovulation if clomiphene citrate and metformin therapy fails. High doses are associated with an increased risk of multiple pregnancies and OHSS. The in vitro insemination is performed as a second-line management of polycystic ovaries with the same dose of gonadotropins is recommended for timed intercourse. The recombinant HCG is administered for final oocyte maturation. Then ovarian drilling is not very much in favor, and 9 to 10 ovarian drills can be done, although in those patients who are not responding to pharmacological treatment. Otherwise, ovarian drilling is not very much recommended. The reason is because it may reduce the ovarian reserve. This is a picture of ovarian drilling done. The third line treatment is in vitro fertilization. In vitro fertilization, if the initial assessment demonstrates a bilateral tubal occlusion or a concentration of recovered motile sperms is less than or equal to 5 million, IVF becomes the first option along with lifestyle changes. In vitro fertilization is a complex series of procedures used to help with fertility or prevent genetic problems and assist with the conception of a child. IVF indications are fallopian tube damage, ovulation disorders, endometriosis, uterine fibroids, previous tubal sterilization or removal, impaired sperm production or function, unexplained subfertility, and genetic disorders. Tests required for IVF are to check for the ovarian reserve, semen analysis, infectious disease screening, and hysteroscopy. So for IVF, you stimulate the ovaries with HMG and FSH, and then eggs are retrieved from the ovaries. These eggs are handed over to the embryologist who makes the embryos. The embryos are cultured, and then embryo transfer is carried out. And after embryo transfer, 14 days after the embryo transfer, tests for pregnancy are carried out. To minimize the risk of OHSS, ovarian stimulation should be initiated with low doses of gonadotropins, and follow-up must be carried out with the E2 and with the follicular tracking. If the patient presents with clinical and ultrasound signs of OHSS, final oocyte maturation should be performed with a GnRH and agonist, and embryos should be frozen and transferred in a subsequent cycle. If you see that the OHSS is very severe, then it is a better thing to do is to freeze these embryos and then do a fresh frozen embryo transfer later on. Infertile women with PCOS may present with better general oocyte and embryo quality rates. Clinical pregnancy and live birth rates are similar to those observed in normal ovulatory women without PCOS. IVF complications include multiple births, premature delivery and low weight, ovarian hyperstimulation syndrome, miscarriage, egg retrieval procedure complications, ectopic pregnancy, birth defects, cancer, and stress. And all these complications, thank God, are very low. The risk of OHSS is the main complication of the highly complex treatment in women with PCOS. In cycles of conventional in vitro fertilization, mild OHSS has been estimated to affect around 1/3 of cycles, while the combined incidence of moderate or severe OHSS varies from 3 to 8%. So OHSS is categorized as mild, moderate, and severe. Women presenting with symptoms suggested of OHSS should be assessed face-to-face by a clinician. Outpatient management is appropriate for women with mild or moderate OHSS, and selected cases with severe OHSS should be then hospitalized. So this is the management. You monitor the patient. You do surgical treatment is very rarely required, and basically the mainstay of treatment is to give anticoagulation and dopamine agonists. The principal subfertility treatment includes lifestyle changes. The first-line drug treatment to induced ovulation consists of clomiphene citrate with timed intercourse. The second-line treatment consists of exogenous administration of gonadotropins or laparoscopic ovarian surgery in cases where laparoscopy is otherwise indicated, for example, for an adnexal mass. If you want, I can just go back to OHSS because this is a condition which can affect in vitro fertilization. And the treatment options include you have to do a strict fluid charting. Plasma and urine osmolality must be measured. Urea and electrolytes must be measured out. Pregnancy tests must be carried out if you have already done an embryo transfer. But if you are suspecting ovarian hyperstimulation syndrome, the recommendation is that you should withhold embryo transfer for a better time when the OHSS is settled down, and then do the embryo transfer. Because if you do embryo transfer with OHSS, there is a chance that there may be an ectopic pregnancy and the OHSS may become worse. So in summary, we have to treat subfertility by lifestyle changes. We may first-line drug which may be given is clomiphene citrate. Then we can later on add letrozole, which is aromatase inhibitor. And finally, we can have exogenous gonadotropins and laparoscopic ovarian surgery if needed. And finally, if nothing is working, then in vitro fertilization is the best way forward. The third line treatment is IVF-ICSI, which is indicated when the previous interventions fail. This treatment can also be the first choice in cases of bilateral tubal occlusion or semen alterations. There is evidence for the use of metformin in subfertility treatment of anovulatory women with PCOS. Aromatase inhibitors are promising, and long-term studies are necessary to prove their safety. Thank you very much. The references here are that of polycystic ovaries in UK Guidelines 2020, Dewhurst, latest studies done on women with PCOS and subfertility, then American Society of Obstetrics and Gynecology and RCOG Guidelines of 2014. Thank you very much, and we can now take your questions. The main review is Rosina has asked this question, Rosina Merchant, that should we do tubal patency test before giving clomiphene citrate just because of the cost, or there's any other reason? The reason is because you all know that tubal patency is an invasive method of testing, so it should be avoided unless it's absolutely needed. And plus, if you're giving clomiphene citrate and later on you find that the tubes are occluded, it's not such a big deal because clomiphene citrate has very few side effects, it is low cost. That is the reason. So we don't want to do tubal patency because of it is an invasive